the observatory hadn't been there, we should invent or found it now.
Many of our partners, member states, they invited us to participate in the reform process, but always as a neutral, as an objective contribution.
For us in the European Union, we request them to support us in almost all the new policies that we are developing.
We all have a common mission: to achieve health for all, leaving no one behind.
I have a responsibility for ensuring that our work is based on the best possible research.
We're not saying this is what you should do, this is what the values that we hold suggest you do. This is about what does and doesn't work.
The observatory has become indispensable in analysing health systems and providing rapid responses on a range of policy issues.
It's very special to work at the interface between evidence and policy making, building bridges between academics and the politicians.
The potential for cross-country learning is enormous, and we should learn how to harness it, and this is what we're doing at the observatory.
When we produce things together, they are really top-notch. So I look forward to the next 25 years.
Excellencies, colleagues, friends, esteemed guests, it's a great pleasure to welcome you all today, to welcome you to celebrate together with us our anniversary, our 25th anniversary, so real jubilee. And I also welcome the many online participants today, which hopefully connect through the chat function and will interact with here discussing the topic we have. But before I go to the topic and pass on the microphone to Joseph Figueras, the director of the observatory, I would also say, by coincidence, this year it's the 75th anniversary of our most ed partner, WHO. So we are celebrating, to some extent, actually this together. The topic for today is how do we harness innovation to improve performance? And almost every word in this title is super important to us, and we believe that the future of health systems and the sustainability of health is in the handle. So that's my little introduction. My name is Matthias Wismar, and I pass on the microphone to Joseph Figueras, our director. Joseph.
Thank you. Thank you very much indeed. Thank you. Such a special moment, such a special moment. What I wanted to do is to start with a very short presentation to try to frame the issue of today. How temptation, I tell the truth, was to drunk with ourselves, how wonderful is the observatory, how many wonderful things I've done in the last 75 years. But rather what we like to talk together is what is coming in the next 75 years. How can we have a contribution together in the next 75 years? And as the English say, you know, the pudding is in eating it. And I'm sure that you've eaten some of that pudding, some of our work, and you have made your mind on whether we should drop it ourselves or not. So thank you for being here, those here in the room and those online. And what we're going to do is a quick framework presentation of a very complex issue, so it's going to be very short and simple, it's not simplistic. And then we'll ask our colleagues here, our panelists, to reflect on that presentation, to reflect from different perspectives, international organizations, national perspective, academic perspective, and so on. And then we're building lecture time to have the people in the room and online to debate on that. Very, very senior people in the room, and we want all of you who are senior, we want to hear your views, your contributions, your particular perspective within that framework. So, I'm going to start with a brief presentation. If you want to put it up, please. The presentation basically is the titles already there, health systems over the next 10 to 5 years. How do we partner innovation to improve performance? And as I said, it's going to be an introductory framework. Yes.
Which is coming any moment. I could start, though I love to talk, so there's no problem at all. So the first slide actually is a tsunami. It's a slide that shows very briefly, I would like to give you all the numbers in terms of expenditure. So this is the first slide, actually. So the focus of my presentation, I said that already, is the how. Our regional director, who's here online, is always sort of talking rightly on the how, on the transformation. So my focus is going to be, in the last slide, I'll make you vote then, if that's okay, where we're going to talk about what are the priority interventions to harness this innovation, to make sure that this disruptive innovation in some instances actually strengthens the performance. And that was my tsunami, basically. I like to spend time on that because there's so marvelous, interesting figures about the impact of the various technologies, about the cost, about the change and the shifting. But I have to focus my presentation shortly on the actual implications for harnessing that innovation. Suffice to say, though, that perhaps at the extreme of that is this work of ending aging. It may sound a joke, but you know the big moguls of the internet are investing billions on living forever and treating aging as a disease. And actually, I agree with some of that work, but just for controversy, we're not going to talk about that. What we're going to talk about is the societal conundrum. Please pay attention to this because it's the core slide I have today. And I know it's very simple, but very worrying. The growth in innovation technologies is exponential. We are kind of aware, we, the stakeholders, policymakers, civil servants, population, but what's really concerning is when you look at the evaluation and regulatory efforts, it's a very slow slope, which is getting further and further away from the actual growth in technologies. So what do we do about that? This is the central question for you today. What do we do about that? Well, you could do what they're suggesting. I want you to find a bold and innovative way to do everything exactly the same way it's been done for 25 years. That's one way forward. The other way forward is going to be like the one I'm going to introduce you today, not rocket science, you're all familiar. So first I'd like you to reflect, please, on the series of questions about this innovation. This constructive or destructive disruption, we hear a lot of disruption, there's a lot of theory of disruption, leapfrogging and so on. What is it constructive or destructive? And what is the impact on the performance of our societal objectives? Value, we need to look at value, and not only in terms of effectiveness, but the responsiveness of the perceived needs and demands of our population, and value for money. In a recent meeting with the medical profession, the argument in the room was, innovation is everything that adds value. The concept of value for money, the concept that innovation is more cost-effective than what exists, was not in the group. If it's new and adds value, it's an innovation. Is that the way we want to define innovation? Even when it's value for money, we have issues of sustainability and affordability. A recent debate triggered by Richard Horton in the editorial in the Lancet, which has been a heated debate, maybe we want to talk about that later, was saying, you know, that sub-Saharan Africa and low-income countries should be able to access new technologies and new innovations in the area of cancer. Is it affordable? Is it sustainable? What is the opportunity cost? There are all sorts of issues in terms of access, equality, and so on. How we balance with citizens' expectations the criteria of value and value for money against the expectations and the political economy. I was talking to a colleague, perhaps he will come up later and say that, who's in charge of a big ministry, who's saying, well, we get lots of pressures for the citizens, for patients' organizations, to introduce innovations, regardless of value for money. And the political economy and the political pressure is very, very strong. So we need to be aware of that. And of course, one of the biggest debates is the equity and access. Is innovation, of course, there are many innovations, of course, an equalizer or an inequalizer? I'm not sure that's in English, but is it equalizing or not? Is the digital technology equalizing? Is this expensive innovation only going to make difference between the richer and the poorer? I know this is not rocket science. I must apologize to make such simple points here, but I think it may help perhaps in a minute to frame the debate. So I continue. Part 2. Impact on performance, impact on the health systems organization. There's a lot of evidence there about how it's going to change. And perhaps what concerns me the most is we still plan hospitals, primary care centers. We still plan the education of our professionals We still work on guidelines as if AI didn't exist, if this new technology didn't exist. Business as usual. There are some examples here. One that interests me, that is a lot of debate, is primary health care the innovation Cinderella is going to lose? Or some people are arguing quite the opposite, with nanotechnology, the ability to do testing at not at the bedside, but at the desk side, as it were, in primary care. Is that going to be the princess, therefore? Hope that is not a gender-biased example. Upheaval in the skill mix. Look at this slide here. This is the work of McKinsey. It doesn't matter. We don't need to look at how accurate that is or not. But we're talking about 50%, 40%, 30% of the hours worked by certain professionals will no longer be needed by 2030. The transparency and accountability changed entirely. Patients will be able to see whether the doctor, the provider, is following guidelines. Guidelines will be available everywhere. Well, the problem will be with AI, of course, and the algorithms hidden in the AI, but that's another story that we'll be talking about as well. Next, is it really, as was said the other day, empowering the patient? Is that your view? That I think it will enable very much self-care. I hope we have here a representative of the Diabetic Association, and certainly for many patients, the innovation and technology has empowered them a lot and allowed them to take self-care. But you find issues as well, such as doctors not trusting these apps, don't trusting these technologies that the patients come with, or the purchasers not paying for these technologies that the patients have. Recent example in Germany that the patients, the sickness funds paid for a certain app, and the doctors say, no, we don't trust it. How we deal with these issues? And is this a new era for public health? I do believe in this case, very much the case. I mean, the way that public health counted with assessing population behavior, assessing risks of those who are more vulnerable for COVID, all the debate about infodemics and the need to counteract infodemics with our own new technologies of communication are very important. Here on the right you see, very well known, this is all technology of course, but using digital epidemiology through social media, monitoring how the populations are changing, are moving, their views, and how we address that as one of the many, many areas we can deal with risk assessment, risk control in public health and determinants. And finally, the how-to, and this is where I like to frame our debate today, if that's okay. Foresight to enable policy decision-making, and I highlight enable. A lot of the foresight is done by some scientific sort of organizations in in a mountain somewhere, remote, doing their foresights with no connection, no support to those policymakers in ministries, in insurance funds that have to make decisions. Monitor and evaluate fast, timely, and effectively. The pace of innovation pushes us to do evaluation in many different ways, mapping very quickly. We'll hear Jennifer Dixon talking about that later. How we fund and incentivize development. The Observatory is working now on a policy brief, how to pay for digital health, how to put the incentives of new digital health immediately. It's not often what we learn in our research is not just the technology, as we'll talk in a minute, is how you embed it, how you incentivize it, is how you regulate it. Far more important than the technology itself. And very importantly, the private sector is pouring billions in this sector. Can we do anything from the public sector? How we steer all this investment? We'll be hearing from our panelists about that as well. And more importantly, how we transfer innovation, implement, sustain, and spread. That's the only area I allow myself to trumpet our work, and this is just part of our work. It's very much an area that we've been working for a number of years already. How do you implement, embed innovation? How do you transfer across countries? Also innovation in terms of organizational innovation, the work we've been doing on skill mix, for instance, the incentives to have new pharmaceuticals, the use, we assess very much the introduction, very fast introduction of digital health during the pandemic, and where were the governance, financial incentives, cultural issues as well. And two of our summer schools have been around the implementation of digital and the implementation of innovation. This is really where I think we need to put much more energy. And finally, in the same vein of talking about the how-to, How we regulate for the unknown. This is a policy brief we did, you recall, Lisa Maria, with the Finnish presidency, which looked at DNA testing, DNA technology. How, as a chief medical officer, you regulate for something that we don't know how it's going to look like? And even more complex, regulating for the unknown unknowns. To regulate for something that we don't know. Because regulating for DNA, we know that, but we don't know what the kinds of technologies are going to hit us any day. How we regulate, how we foresight for that. How to regulate professionals or algorithms. Really, now the focus is regulating algorithms. I already mentioned the need to reform the health professional education for new needs. And importantly, I've been saying that earlier, how we involve the population and civil society in this innovation. Patient associations, groups like that are fundamental to adopt, to assess, to integrate innovation. They are really, really leaders in many of these areas. So the literacy issues, the involvement is very important. That book I recommend. They started using AI to make ChatGPT for medicine. And actually, they're all case studies. Some is bizarre, but some is much better what the doctors are doing. So there you are. But what is the future of innovation? Is it the future, or is it this one? I do believe in future the human contact is going to be the most scarce, the most expensive, and the most disruptive kind of innovation, because still the health system will need a lot of that human contact to keep going. Thank you very much. Now I'll let you vote. Please beg you to vote, rather. Are you projecting the Slido information for those online and for those, yes, if you could look at this, please do join me. Please do join me voting, otherwise it's very bad if I get 10 people voting only. We need representation, those online as well. I think you can see your, but I cannot see it, so I'm gonna list it for you because you can see it in your apps already, in your telephones. Oh, it's there. So foresight, you already heard that. So you have to choose 3. I know it's inappropriate to ask you to choose for 3 because they're all important, but we wanted to get a sense, at least push you a bit to reflect how we steer, how we harness all this performance, or all this innovation for performance. Monitoring and evaluation, funding and incentivizing, transferring innovation, reforming the way we regulate, as I said earlier, or even more regulate AI algorithms, reform professional education to adapt to new needs, and involve the population. So we're getting some results here. I ask the panelists, please, to pay lots of attention to these results, because I'll be asking you for these results. Okay, it's very interesting that the most important one is involving the population and health literacy. So empowering the population to make their own decisions. I like that, actually. I like that very much, and I was not expecting that. I was not expecting that. Reform the education, also surprise. Foresight, yes, excellent. Not that much support about AI algorithms. Of course, you have to choose, and you have to choose the most important ones. Incentivize development and adoption, that surprises me a bit, because I believe, as you see, I'm trying to manipulate your voting here, you know. Transfer innovation, not as high as you would expect. Very interesting results. I think you need to change your presentations, RD and colleagues, in light of what you're hearing here, because I think I didn't ask you questions about how we involve the population in my preparations. I'm the first one that I haven't done my job very well. Thank you very much. So I will start there the debate now. We asked first the regional director to give us a speech about the presentation, a keynote about the view from WHO of innovation. What is the role of the World Health Organization on steering, supporting member states, learning from that regulation, getting the best regulation out there, particularly for public health and primary health care. And thank you for this beautiful, I don't know who's this handsome man with you, but It's very nice. I know who he is, but great. A recent coffee where we actually baked this presentation, Hans and I, the other day in Zaventem. Hans, we're really, really grateful you are here. You'll be here for the whole session. You're a bit sick, you couldn't be here at last minute, but I'm very grateful, nonetheless, that you are online for 2 hours.
Thank you. Thank you. Do you hear me well, Josep?
Perfectly.
Excellent. Excellent. So, here, Dr. Lisa Maria Voipio Pulki, chair of the Observatory Steering Committee meeting, my dear brother Josep, ambassadors, partners. As Josep is telling, I would have loved to be with you, but as actually Isabel could witness when she was here for our technical advisory group on One Health in the beginning of the week, I was still wearing the mask, recovering from a bronchitis, but I will stay definitely the whole afternoon to commemorate this very important silver jubilee for the European Observatory on Health Systems and Policies, which actually fills me with excitement and with hope. I always say that Josep was the one who introduced me to the field of health systems when I came from Myanmar in 2009, and my baptize actually was in Gastein, the then director of health systems in WHO Euro, Dr. Enes Baris, couldn't go at the last moment and threw me into Gastein, where it was Josep and Joe Kutsin who introduced me to the whole field, including one of the first introductions they did was to what they call the guru of public health in the region, Professor Mark McKee, who also became a very close friend. And very important, very quickly, I got to know that if you want to get something done, when you have to go to Josep Figueras and when you have to go to Suszy Lessof to get something done, which was also very important. But my friends, the past 25 years have been instrumental in strengthening health systems, thanks to the crucial role played by the observatory. Now, as we project into the future, as Josep was mentioning, the world is faced with unprecedented opportunities, driven by emerging technologies and innovations to revolutionize healthcare. Europe, at the forefront of cutting-edge breakthroughs, has shown remarkable progress in digital transformation. From electronic health records to telemedicine, mobile health applications to digital solutions, we have embraced these advancements as we showcased recently at our second WHO European Digital Health Forum in Porto under the guidance of Dr. Natasha Azopardi-Muscat, my director on health systems. Now let me quickly review the prospects before us in technologies and markets. In artificial intelligence, for instance, the current global market is valued at around $14.6 billion in 2023 and is projected to reach over $102.7 billion by 2028, highlighting the immense potential and market demand for this technology. Virtual reality is used for medical training and simulation, allowing healthcare professionals to practice complex procedures in a realistic, risk-free environment. Again, the global market for virtual reality in healthcare is projected to reach $5.1 billion by 2025, reflecting the growing market interest and adoption. In tandem with emerging technologies, the life sciences sector is experiencing a profound industrial transformation. Breakthroughs in gene therapies, personalized medicine, regenerative therapies are opening new frontiers in treating diseases. The global regenerative medicine market is expected to reach $39.4 billion by 2025, driven by the increasing demand for innovative therapies that can regenerate and repair damaged tissues and organs. Further, the global personalized medicine market is predicted to reach $3.2 trillion by 2025, reflecting the growing recognition of the importance of tailoring treatments to individual patients based on their unique genetic makeup and medical history. These market figures provide a glimpse into the immense potential and economic opportunities that innovation in healthcare presents. But it is important to remember that innovation is not merely about market growth. It is about improving patient outcomes, enhancing access to care, and addressing the pressing challenges we face in healthcare in an equitable way, leaving no one behind. One area where innovation can make a significant impact is in the management of non-communicable diseases, NCDs, such as cardiovascular disease, cancer, diabetes, and chronic respiratory diseases, responsible for 9 out of every 10 deaths in our region. Our office, WHO Europe, has now embarked on what I call a dual-track approach for NCD prevention and control, and I'm so proud, my friends, that we welcomed recently back one of our other brothers, the previous WHO representative to the People's Republic of China, Dr. Gordon Galea, a good friend of many of you, who is now my senior strategic advisor on NCD prevention and control, taking charge of this field here in the office. Dual track. One track is termed race to the finish. We call it race to the finish. It aims to accelerate the attainment of the NCD-related SDG targets by focusing on those public health measures that will give us a rapid return in the remaining years leading to 2030. A shift from best buys to quick buys, leading up to the UN high-level meeting on NCDs in 2025, where we have very concrete targets to obtain. Then a second track, more long-term, which we call Vision 2050, focuses on achieving a generational shift that addresses NCDs in the context of the longer-term conditions that cannot be solved in a matter of a few short years. Conditions that include our state of perma-crisis in Europe or the commercial terms of NCDs. We will present this dual track at a ministerial lunch at the first day of the Regional Committee in Astana in Kazakhstan, 24 October. As we embark on this dual track response, we do understand that business as usual will not get us there. We seek answers to a myriad of questions. How do we harness the power of these innovations and market forces for the good of public health? Can we leverage digital technologies, predictive analytics, and telemedicine to revolutionize this dual-track approach to NCDs? How can health systems be reimagined in Europe to extract value from these new trends on behalf of the whole population, not just a few? How can we govern and steer these innovations, increase the capacity of the public sector to innovate and finance new solutions, delivering them at population scale, not at pilot projects, but population scale? How can innovation be used to help the poorer countries and communities in Europe leapfrog their disadvantages? And as Joseph mentioned, what are the complementary roles of the public and private sectors in public health innovation? Here, the WHO Regional Office for Europe is also taking a pioneering role, be it on the platform with public and private sector to work towards equal access to innovative medicines or on digital solutions. Moving forward, we at WHO Europe have an ambitious an ambitious vision for the future of public health innovation in our region. For the first time, we have now a dedicated officer, medical officer, working under the guidance of Gordon Galea on innovation. Over the next 2 years, WHO Europe will focus on 3 primary areas of action in innovation. Number 1, we will deepen our efforts to cooperate and collaborate extensively with innovation ecosystem players throughout the region and beyond. And this will include a determined drive to foster robust partnerships with innovation hubs, aiming to uncover and nurture promising new strategies for enhancing public health. By escalating our capacity building initiatives, it's our goal to empower member states to create an environment conducive to these pioneering developments, providing the vital link between public and private sectors for effective acceleration of health outcomes. Number 2, WHO Euro will dedicate resources to the creation of an innovation marketplace, a focal point for innovative thinkers to display their solutions and for policymakers to discover promising new collaborative opportunities. The intent is to expedite the adoption of the disruptive technologies and methods, enhancing equal access to healthcare and pushing boundaries in the public health sector. Remember, we started this in Tallinn 5 years ago under the 3 I's: include, invest, and innovate. Lastly, WHO will amplify our strategic alliance with academia, research institutions, and industry leaders. A united front is essential for driving innovation and for creating solutions that serve the most susceptible communities, prioritizing the need to overcome healthcare disparities. Very ambitious agenda, but I'm very, very confident because the innovation officer, Dr. Mo, came from the African region, and he's the one who was the penholder of the first region strategy on innovation in the African region. And what the COVID-19 learned is that there is no more traditional North, global, South humanitarianism. We can learn a lot from the African region. And second, Gordon Galea himself was responsible in the West Pacific region for the first regional innovation strategy there. So we have the 2 key players to work on a WHO European strategy. Innovation and evolution, we firmly believe, should not be limited to technology and hard science. We will promote the adoption of creative healthcare delivery methods, embracing cost-effective, high-quality approaches, such as the frugal and social innovations. And we are very eager to learn what works in another region, such as Africa, and adapt it to suit our region in a genuine 2-way partnership. I'm finishing my talk for the Region Committee, 24 October, and I will make a point there on inter-region collaboration. We have great collaborations with all regions, which strengthens the internal coherence and unity of WHO as a whole. Now, looking to the future, the path to harnessing innovation in health systems may be intricate, but with the combined efforts of the WHO, Euro, the European Observatory, and all our valued partners, we are filled with confidence and determination. United, we are prepped to serve the vulnerable, promote global health, and safeguard the world from health crisis through innovation. Thank you so much for partnering with us in this transformative journey. Together, we will shape a better future. United action for better health. Thank you.
Hans, that was brilliant. Thank you very much. Even higher than my highest expectations. Thank you very much for that. There's so many points I'd like to raise, and I'm sure our participants here will raise during the debate, and thank you for being with us. I mean, partnership, collaborating with these innovation ecosystems, marketplace, alliances, is the only way we can deal with this tsunami, is the only way that we can manage to really harness, steer that. And I think the WHO with its convening power, with this strong view of, a strong position rather, of not leaving anyone behind, which is one of the main concerns with innovation, it's very well placed. Thank you very much, Hans. Stay please, because after this panel, we'll have lots of questions and views from the participants here. Thanks again. Isabel, I'd like to introduce now Isabel de la Mata. Isabel de la Mata is the Principal Advisor for Public Health to the Director General in DG Santé. Isabel, the EU has this enormous power, the power of regulation, if the member states give it to you. That's the problem, isn't it? My view on that, and it's my view, so don't take me wrong, it's my view, Joseph, is not the view of the Observatory, and I've been testing that with some policymakers, some ministers, is that as this tsunami increases in exponential growth, I don't think individual member states will be able to regulate, to evaluate, to understand what's going on, and they will go back to the Commission, maybe consider the subsidiarity element. You don't need to agree with me, none of you, and ask the Commission to play a role in helping to regulate, evaluate, and so on. I know you're a civil servant, you cannot agree with me, you will not agree with me, I know. But Isabel, how do you see, not only the current, we all know what you're doing now, but can you see, how does the next 25 years look like for the European Commission? I know maybe you and I will not be around, but we'll be around, alive, I hope. I'm planning to retire very late. So, what is the EU now doing on regulation? The Parliament actually has been at the cutting edge on looking at AI. How is Santé looking at that? How is Santé looking at evaluation and monitoring and foresight to support their member states? One aspect that you may not like, but I do believe that joint purchasing is a way to go to access this innovation. I'm provoking you a bit, Isabel. Start wherever you want and I'll keep asking you questions.
Thank you very much, Joseph. For sure, I will not be there. I don't know even if I will be in this war in 25 years, but I am sure that there will continue to be health system. So for next 25 years, I don't know how they will look like, but there will be a health system. I remember there is an old TV series, the Star Trek, but the real one, I mean the original one from the 60s, where there was someone that was the Dr. McKee, and he was like approaching the patient and doing, and like that had the diagnostic and then the treatment. That was the beauty. And we are a little bit approaching that, and I think that with the artificial intelligence, we are approaching that. So something that we dream 50 years ago now is coming, or could come a reality. So what we are dreaming today, maybe in the 25 years will become a reality. We are doing regulation in the European Union. We have already proposed, at least, I have here with me, 3 different pieces of legislation: the Artificial Intelligence Act, the Products Liability Directive, and the Artificial Intelligence Liability Directive. So, because, and one of the issues, and that was also identified in the speech last week of the President of the European Commission, Madame von der Leyen, was that she called for a new global framework for the deployment of artificial intelligence, and also mentioned the potential of artificial intelligence in healthcare. So, in one side, I think that we have been paying attention to the development of artificial intelligence, but not enough attention to the deployment of artificial intelligence, and for sure, not in the healthcare. And why is that? You are right that we don't have an harmonized regulatory framework, not for health, and we are indirectly, but also going to work more in that area. The European Health Data Space is one piece of legislation where we are working on that, but also take into account that artificial intelligence, and we tend to put everything in boxes, and in these boxes, the artificial intelligence for us is medical devices. So it's not pharma, it's not direct, it's not health professionals, it's medical devices, and we have legislation on that. But we are working on that. And one of the issues also that, or one of the challenges is the trust, but also the transparency in both sides, in the health professionals and in the patients. Well, I have seen that involve the population is one. I mean, what the room has decided that is the priority. But I still remember when the medical, the healthcare workforce or the medical professionals were saying that collecting data that was not for them, that was for the secretary, because it was not part of the medical act. I think that now nobody thinks like that, and we see and everybody that the data, the information is part of the medical act, because otherwise you cannot provide.
What can you? I mean, you have the digital initiative, but are you planning to step up massively to have this kind of transparency, that trust, that involving the people in understanding the populations? I mean, in understanding what's going on, because the digital health is taking a long time to move the data.
The European health data space is taking a time, but we are nearly there, and I think that we also tackle already the trust or the transparency. In fact, one of the issues that are delaying the legislation is the secondary use of the data. So that means that people and the parliament, especially, that they are aware and they want to discuss these kind of issues, and everybody sees the benefit, but also the difficulties and the challenges that the digital, the artificial intelligence, all that could pose. I mean, 5 years ago, when you try to show to one of these machines of artificial intelligence, and we had a live demonstration to show a cell, the result was that was a pizza. Because something more or less round with different elements, so this is a pizza. Now they are given a different diagnosis, so it needs to continue, I mean, being fit and to provide the results, but still is making some mistakes, less and less, but when there are those mistakes, who is going to cover that? This is also the issue of liability.
Shouldn't you be the ones regulating? Shouldn't be the ones giving the transparency? And do you think, Isabel, the current efforts are good enough, given the exponential growth? I know you depend on your member states to ask you to do more work, but you think these efforts are strong enough to deal with this challenge?
They are first efforts, and I think that we cannot go from here to here without stepping in the middle. And I think, yes, I am convinced that the European Union is the right one, because the member states but will be maybe, in my view, not adequate, that everybody is regulating in a different way, because at the end, we will need to share the data. We are already sharing the patients, we are sharing the health professionals, sharing the services, so it will make sense that there is an overarching legislation, whatever the name, that support the member state, but we cannot do without the member state, we cannot do without the stakeholders, the parliament and all the different social actors, and making sure or ensuring not only the patients. I always say that when we are patients, it's already too late. It's about citizens, that they are going to have all the benefits, but as less possible harm as is feasible from all this system, the artificial intelligence, whatever. Because it's true that all the digitalization could support us, for example, in the medical desert, in the population that cannot go to a healthcare service easily, but at the same time, we need to be sure that we are not increasing the inequalities, that is not putting more problems for the elderly, for example.
That's one of the challenges.
I think that, and everybody is mentioning the COVID as the big push for the digitalization during the pandemic, but I think that this also made a lot of harm with all the elderly that stayed at home with a physical telephone or with all mobile telephone without any intelligence, if I can say like that. And when they try to connect the healthcare service and say, but I have that, but show you how, if I don't have a telephone or what.
There's an equity on aging as well. Suszy was raising that yesterday. Isabel, I think you raised very important areas, and we'll want to have lots of debate with you that I'm sure you want to come back to about the role of digital, the role of data, the role of regulation. And I expect you asking questions as well about financing some of these services to get access across the EU and the less privileged countries of our EU. Lisa Maria Voipio-Pulki is the chair of the European Observatory. But she's much more important than that. Observatory is very important, but Lisa Maria is the Chief Medical Officer in Finland. So one of those who has to deal with all this tsunami in innovation, advised her ministers over the years as how to address that, how to integrate that. And also very importantly, Lisa Maria was an intensivist and head of intensive care unit, so being very used to innovation and the adoption of innovation. Lisa Maria, you have quite an interesting view of the innovation and productivity. You're saying why healthcare should be different from other areas. You know, we have to go for it. So can I hear more about that? And can I hear, in your double perspective as having been, or being a doctor, still you're always a doctor, and being a regulator now in the ministry, how do you get with these incentives, these regulations, this transfer of evidence? So give us a few minutes on that, please.
Colleagues, it's really a tough topic, and you made us spend a few hours on thinking of how we can get some order out of the chaos, so to say. So I wrote a couple of slides to make it easier for myself, and I hope also for you to follow my thinking. Well, health systems are special because they are so complex and intricate. So revolutionary innovations, for example, the introduction of thrombolysis and PCIs for acute myocardial infarction, often lead to widespread effects. In this case, which I remember from my previous life in cardiology, major reorganization of the entire out-of-hospital care and emergency care. But not all health innovations are that fantastic. And then the question is, how can we know which ones will really improve the performance of our system, which is the topic of this event, this important event? Well, from the macroeconomic point of view, the health sector is basically an industry among others. In other businesses, technological innovation is a major driver of productivity. Otherwise, the new processes and products wouldn't fly. From comparative macroeconomic studies, we know that countries with a rapidly elderly population and sluggish uptake of new technology, they tend to be lag behinders in labor productivity and have problems with public debt. We also know from technology diffusion studies that it takes a long time, 10 to 25 years, irrespective of the industry, from scientific discovery to large-scale implementation of an innovation. Well, I think that productivity is definitely an issue for health systems, and I think that we all believe that innovations should help. And in that respect, the health sector should not be viewed differently from other sectors. However, can we wait for 10 to 25 years before we know? If not, then the question to us as health policy advisors, health policy makers would be, are there special mechanisms and incentives that could speed up evidence generation and justify scaling up of innovations? I believe that this is where governance and R&D leadership actually can make a difference and should step in, although the academic community would not necessarily like it. Well, in other words, how can we harness the outputs of our R&D ecosystems so that health-related innovations would be needs-based and timely? That's a burning issue, burning question. We actually believe that a combined bottom-up and top-down approach and facilitation is needed, exemplified here by some citations from the recently adopted program of Finland's new government. Well, political will and multi-sectoral stakeholder agreements are certainly helpful backups. But lifting obstacles and providing opportunities at the grassroots level should be combined with strategically targeted cooperation between the local, regional, and national R&D actors and stakeholders. So it needs both. Both levels of governance are needed and must be developed hand in hand if we want the R&D ecosystem to deliver efficiently and to be responsive to the needs of the population, the pressurized health sector, and at the end of the day, also the national economies. So, what does this really mean in practice? Well, every country has its own bottlenecks, and I'm using Finland here just as an example. For us, first, facilitating public-private partnerships and ensuring enabling legislation without compromising data safety and security. They are strong interventions and will lift obstacles at the grassroots level. On the other hand, technology assessment and quality registries are often viewed as filters that only make it more difficult for new products to enter the market. Well, such measures, I think, could also be viewed as top-down mechanisms to incentivize companies to collect the necessary evidence. Well, last but not least, as all primary research is increasingly data-driven, collecting and then allowing safe and secure access to health and other personal databases is a must for both health and economic research. Well, it takes investments, but will pay back in the form of better evidence for policymaking, investing in health, and understanding the economy of well-being in practice. Well, inspired by your most important slide, I would like to be a little bit philosophical at the end. Well, academic freedom cannot be limited, and nature will continue to reveal her secrets. Innovations do originate primarily, often academic research, but they must be tested and matured in cooperation with the service system. It's a long road from scientific discovery to evidence-informed change in practice, either process innovations, which usually involve digital tools, or commercialization, which is a prerequisite of managed product uptake. Risks are high at all stages and cannot be fully predicted or mitigated. Therefore, I think it is essential for governments to harness health innovations also by building up real-time information collection and analysis systems of what is going in the health sector and how interventions do or do not work in the real world. Those were the thoughts that you provoked me to write down. Thank you.
Thanks, Lisa Maria. That's exactly that. Perfect. It's our debates we had on this area. You're saying, why are we different? And actually, it's true. Why some innovations take such a long time to be implemented? Actually, sorry if some of you have heard my physics theory, which is innovations travel the fastest when there is less evidence, because evidence is heavy, and they don't stay. They don't transfer. So the less evidence, the faster they go, and the more they are adopted. And that's our problem, isn't it? That some innovations that actually have very little evidence, but very, very attractive, because we don't know what happens, they're adopted faster than those actually that are cost effective. But that's a very good point about academic freedom, about the scaling quickly, and about the kinds of collaborations with the private sector, the kinds of cost effectiveness analysis, and particularly, again, this academic freedom. We cannot constrain innovation. I like very much because you counterbalance some of the things I was saying earlier very effectively. Thank you very much, Lisa Maria. I now have Jennifer Dixon. Jennifer, I'm an admirer of you, as you know. I've been following your career. You are now the director of the Health Foundation, I think it's the largest foundation in Europe. We go from a policymaker, Lisa Maria, to an institution, an individual who's been there supporting policy, providing evidence for policy over the years, and now from the Health Foundation, a role model for us, you do a lot of research that then gets translated into National Health Service as well as internationally. So, Jennifer, you and I, when we were talking about this, you were worried, as I was, about this fast development, exponential development of technologies. You are worried about how to spread them, how to integrate them, a bit the issue we've been repeating again and again. What kinds of work you're doing to map, to evaluate that, to support the innovations that need to be integrated and to kill, to say it in a harsh way, those innovations actually they're not value for money. Well, how does the foundation work on that?
So can you hear me, everybody? Yeah. So thank you very much, Joseph. And the first thing I must say is congratulations after 25 years to you and your team. It's a wonderful opportunity, and I'm very pleased to be here today. The second thing I want to say is my comments really come from the perspective of the United Kingdom, which, as you know, is a very centralised healthcare system, very centralised other things as well. The National Health Service clearly publicly funded out of national taxation, and we have an issue, as many countries represented here have, as Lisa Maria talked, the economic weakness, high fiscal debt, inflation on the one hand. We have demographic change, we know about that, an exponential rise in the next 30 years of older people because of baby boomers, at the same time as the working age population is relatively smaller to support them. We have climate change. We also have a health fabric that is not improving as fast as it has done over the previous decades, and loaded with risk factors such as obesity. So in the NHS over time has eaten up more public sector spend than everywhere else in the public sector, because it is not possible to turn the taps off, it is not possible to control demand. And it's not possible, looking at future costs of care, that can be loaded elsewhere onto the public or onto businesses. So really we are going to stuck with the current model, and we have to make it work. The National Health Service itself has the most enormous assets, in particular a single data source, which is an enormous asset, and we have a very strong life science industry, and we can coordinate strategy nationally. So those are good things. So I think, and I'm starting at this place for a reason, the future is, I think, as we all know, we need to move more into prevention, in particular social determinants of health, supporting people at home, supporting informal carers, supporting dying, because that's going to be a growth industry, support personalised care, have labour-saving efficiency technologies, integrated care, and manage risks that we will all have, because we will all know a little bit more about our future risks of ill health if polygenic risk scores take off. So that is the context. And that's important in how we promote certain sorts of technologies over others. There's an enormous opportunity from technology, but we have to bear in mind public objectives to meet those challenges, rather than very powerful private objectives, which may be very, very different. So that's the first thing I wanted to say. The second thing is, like in many countries, and this is where I turn to a slide, we have an innovation pathway which will be familiar to you, from creation to development to regulation to endorsement and reimbursement to commissioning and adoption. And there are 4 things I want to say about this pathway. The first thing I've already said, this pathway has to work for public objectives, not just private. The second thing is, I think we all know we have to speed up and streamline this pathway, not just regulation, but also other bits.
Jennifer, don't you think that sometimes it goes from creation to adoption? Don't you think that sometimes this pathway...
yes, not in the UK, because it's a public payer, so we can control that.
Can control. But even in the private sector comes with an innovation. How do you damn the expectations of the population that want to to want that, have that innovation. Because it's one of the political economy issues, isn't it? The pressure of the citizenry when they see that something is being created, new DNA, whatever sort of test. How do you do that?
Yes, well, I think that is where, as we've said, some other people have also said, there has to be a deep compact with the public about what is possible and what is affordable, at least in the public space. Yeah. I didn't see any way around that. Yeah. Just on this slide, the third thing I wanted to say about this slide is that the kind of the private sector and scientific philosophy a lot of the time is to have bottom-up development, and that is the best way to discover new things. And that is surely true. But there is also room for national demonstrations of really game-changing good bets to try those to speed things up. And the fourth thing, of course, is far more attention needed on the right-hand side of this, which is adoption as opposed to always creation. And so I think for the NHS, before I finish with the final slide, we need to do better demand signalling about what we want publicly, to have much more support and formative testing using rapid formative evaluations, streamline regulation, evaluate and design reimbursement, but have much more formative evaluation after regulation to have rapid support and to fund not the tech, just the tech, but to fund the support, which means skills, robust quality improvement methods to try that. And of course, there are lots of implications from that we can talk about, and I haven't got time. So the very last thing I wanted to say was that nowhere is this truer than, of course, artificial intelligence. And in our analysis, the healthcare has been slow to look at AI. We have just done some analysis of all the issues we think are being raised. I mean, I'm sorry about this, is so busy, but there are a huge number of issues to do with AI in healthcare. And if you look at all the work that needs to be done under each of those boxes to get an intelligent approach to this, then that is the task at hand. It's too big for any one country, we've said. There are developments with the EC, with the National Academy of Medicine in the US. In Britain, we are beginning to develop, particularly on the regulatory side. OECD, WHO, we need to collaborate. We should collaborate. And it's not just about regulation either, it's also the public compact. So that's the thing that I would like to say. And just to say, unless we do all this, we will not have the quality service or resilience that we need in future. And there's a key role here for the Observatory as a possible convener of this kind of collaboration. Because unless we do it, as you say, we will be overtaken fast, and the fastness will mean that private objectives will win out over public. Thank you.
Perfect. Thank you very much indeed. Thanks. You raise key aspects as well, many ones that our colleagues will raise, so I don't need to repeat them. One, I thought you're aligned very much with Lisa Maria between the top-down and the bottom-up. And in many ways, the kinds of steps you put on the table there, the same steps that Lisa Maria put, a lot of convergence put in her slide as well. Also, the issue you raised, and I'd like to echo Jennifer, is the capacity issue with all these steps in AI. I mean, it's daunting, isn't it? So either we collaborate internationally or we are in deep trouble. I think that's what this slide is telling us very clearly and very loudly. Last but not least, I have Kairat Davletov. Kairat is a professor at the National School of Medicine of Kazakhstan. Kairat, like our other panelist, combines many particular competencies which are very useful today, very relevant today, rather. Kairat is a cardiologist, he's an academic, has been writing a lot with actually with Martin McKee and Bernd Rachel here in many areas. And Kairat has been working as a public health specialist with the SID across the region, across the CAR countries. Kairat, one of the issues that the regional director as well has raised has been around the low-income countries, no one left behind, the low and middle-income countries. We talked about frugal innovation. We talked about primary health care versus specialist care, even more important in these countries. And one area that is particularly relevant to you, to the NCDs that RD was raising, cardiovascular diseases, being a cardiologist. So can you give us a sense, double sense as it were, how much is innovation helping really on the screening, on the detection, on the prevention, primary and secondary prevention of cardiovascular diseases, a measure impact on chronic diseases and mortality and morbidity, number one. And number two, how does that innovation, is this innovation accessible in primary healthcare? Is it accessible in low and middle income countries? Do we see frugal innovation that can be adopted? Or we're really increasing inequities with these countries, East and West, but also within the countries themselves? Not an easy set of questions, Kairat, but I'm counting on you.
Yes, thank you very much. Because really, I don't have any answers on these questions. Just wanted to say, and especially region, our region, Central Asia, is maybe not everybody knows why they actually belong to WHO Europe, just because we are former Soviet Union countries. And Central Asia actually is quite different. You know, we have a low-income countries, and Kazakhstan is a high and middle-income countries. Just for you to know, just September 1st, our president gave a task to the government to increase GDP twice per year, 2028. So just for you to imagine, in the 6th year, our GDP will be doubled. So, I mean, it's just for you to understand what the ambitious and what the, what the strive to innovation actually exists in our country. In our country, we have now funding for science increased twice or even more for the last 3 years. And I mean, this all came with our new president. We have we call it New Kazakhstan, Jana Kazakhstan. I mean, sorry for this praising our government. I never did this, but
you're no longer a lower middle income country.
Yeah, I mean,
I have to stop you there.
Anyway, I want to say that I would prefer that if there would be any innovation, I would prefer that this innovation would be in primary health care settings, not in hospital cares. Because what our government and authorities like, they like to put a fancy machine in a hospital, and maybe even we don't have doctors, they have qualified staff to treat it, to use this machine. But I would prefer we to have to use this innovation, as you said, frugal innovation, whatever. I mean, it means that it covers more or less universally people, and this only possible in primary health care. And of course, I mean, this could be everything. I mean, these smart watches we use, which I use to measure my blood pressure every day.
As a cardiologist, let me ask you, I wanted to ask this question all my life.
Yeah.
As a cardiologist, do you like people when they come with their app, with their results of their monitoring to you?
Of course, yeah. Because
you find that useful?
Of course.
Doesn't create demand that is not needed.
This is very good because people, this is about patient involvement. I think you mentioned this, about patient involvement, and I wanted to tell about this in my mentioning Amata Declaration. That was one of the basic, principles, patient involvement. And that's why it's very important that patients would monitor their pressure, patients would monitor their glucose level, patients to monitor their cholesterol level, or whatever. So getting to my second bullet point, it's prevention in cardiology really has amazing opportunity. Now we have a drug. I mean, I don't want to say a name of this to make any advisory, but this is from the group of PCSK inhibitors. And I mean, you can use this drug once a year, injection once a year, and your lipid level will be low. I mean,
is that affordable though? Do you think the prices?
Now it's,
I believe it's quite expensive.
Now it's expensive, but even governments of Kazakhstan now put it in so-called list of essential drug lists. So I mean, this
I think that's cost effective and worth introducing.
I think in the long run it will be cost effective. And just want to mention, you asked me to say about what will be in 25 years. Just last year, prominent American cardiologist Jürgen Braunwald published a paper in European Heart Journal, and it calls "Who Wants to Live Like Forever?" something like this. Who wants to live up to 100 years old without any cardiovascular disease? So he suggested to use this drug, as a vaccine, every annual vaccine, which we use like a vaccine for flu and probably for COVID in the future. So maybe in the near future, young people, like 30 years people, will start vaccine with this type of drug, and they will never have cardiovascular disease. Who knows? This could be a future in the 25 years, and this is based on research evidence. And this could be a secondary prevention, because people in our country, I mean, even after myocardial infarction, I wanted to show a slide, but God didn't allow me. 33% of people after myocardial infarction don't take, only 33% take statins. And only 20% of them who take statins, they have this target level of LDL, So you can imagine 5% are treated effectively. But using this innovative drug, you can get a much more better health outcome. So I mean, this innovative diagnosis and treatment will certainly improve, we believe, health outcome in Central Asia, when people don't have, access to qualified healthcare, or, for example, even recently in our university, some people brought a new project. This project is based on the German innovation. And it allows to detect, it's not about cardiology, but it's still amazing. It allows early detection of cataracts, by using this device. And this device can be used by any low person, not health qualified ophthalmologist, and you can teach nurses, and she will do it in remote areas. I told you, in Kazakhstan we have remote villages which is 500 kilometers from the nearest city. I mean, this is a huge country.
Yeah. Can you push you now forward on that's very enthusiastic approach to technology and innovations, and you made the case very effectively. Can I now push you further on the low middle income, because Kazakhstan is no longer middle income, it's becoming high income, and reflect a bit on how do we introduce all these, what seem very cost-effective innovations.
Yeah, but I also want to mention about, with all pros, cons comes together, and there is a lot of challenges with health innovation, and not only in low and middle-income countries, but everywhere. If somebody, I believe many of you probably saw a documentary movie on Netflix. If you haven't seen Bleeding Edge, it's astonishing. Even the US don't have regulation for medical devices. No regulation at all, almost. So you can and people use any innovative devices without any innovative pathway, we just shown. And this is a real problem if it comes especially to low or middle income countries where there is no strict regulation at all. So it could be very dangerous, problems. So I don't want to take about every challenges I put on the slide, but it could be even language problem, or some cultural problems. Devices comes with usually with qualified staff, and sometimes we don't have qualified staff even in Kazakhstan. You know, like I just was bragging about our future success, but. For example, just recently, 2 days ago, we met with the State University of New York, and they are ready to invite 10 people for the master's degree. Like we can't find people with good knowledge of English. You know, this is also about innovation. You mentioned innovation is not about device only.
Exactly.
It's about all these, changes in even in education and that's all. And all these problems, they can come with uneven distribution. In Kazakhstan, we have rich people, we have poor people, and there could be even widening. So who will have access to these devices? Who will have access to this innovation? I'm sure it's not people people in the rural area, not poor people. So, and also lack sustainability, everything you mentioned. And as Hans just mentioned, WHO needs more attention to, I mean, I wrote WHO needs more attention. I mean, I used to work in international organization, USAID. All the money, all activity goes to TB and HIV. I know this very well. No project, no activities in NCD area. And I send you, we have a disaster with NCD. We have disaster with cardiovascular disease in our regions. And this actually connected with risk factors. And we need more research in this area. And Martin, one of the few Western academics who works in our region, she's a guru for us also, who works in all former Soviet Union countries. So we need more research, we need more data to access. For example, this device I just said, coming from Germany, but this detection of cataract can be done on the database. And database exists in Germany. It doesn't exist in Kazakhstan. So we need to do this research.
Thank you.
Research. Sorry for a long time.
No, not at all. No, I think it's very nice because in that list actually you have there shows the similarity of the issues as you would expect anyway, the similarity of challenges. There are many things I like to highlight. You echoed the points of Hans as well earlier. But what you're saying basically is, yes, primary care can be the princess, as I said earlier.
Yeah.
Primary health care can have the kinds of innovations that they can be frugal and affordable, and it's not investing in devices, but investing in people. Not only the health workforce, but also, as we heard from our vote today, those populations of civil society. So that's absolutely perfect. May I thank Isabel, Lisa Maria, Jennifer, and Kairat, all of you. Thank you very much for your contributions, but you're staying here because the real debate comes now. For once, maybe as I'm getting older, I think I finished about the time how you asked me to finish. No, Dimi? Come on. Yes. So please, an applause for them, and now we're going to have some facilitation.
Thank you very much, Giuseppe. Thank you, everyone, for listening and sticking with us. Now we pass the floor to you. So do you have any questions or insights that you would like to share with the panel? Charles.
Thanks very much. I was struck by the one set of ideas that was missing from all the presentations here, and that is the whole area of intellectual property and how we manage the whole relationship between innovations and the rights that go with them. And I would be interested in a little bit of thought about how our years of experience of having bad intellectual property management around pharmaceuticals and fairly bad intellectual property management around devices, and yet we haven't really addressed this as a central issue in the whole debate about developments and innovation.
think we have one over here and might be a direct reaction to Charles.
It is not directly, but it's first of all a congratulations to you and thank you very much for the invitation. But it's a question about a kind of innovation that we haven't talked very much about. My name, by the way, is Hans Martens. I'm chairman of the European Association for Value-Based Healthcare and a number of other things, just so you know who I am. But we have talked a lot about innovation, but not so much about innovation in organization. And I think we all talk about the needs of transformation of the health systems that haven't changed so much over years. I don't know if you agree with me on this, but if you do, could you also let me know why so little is happening? Is it because it's more difficult to make innovation in organization because maybe of the silos we have, maybe because politicians are a little bit afraid of it and so on and so forth? But one of the major things that we probably need to do is, I think what we just touched upon here, is the move from sick care to health care and also to go to more prevention and so on and so forth with all the challenges we have. And let me add to that, I think that it would be good if we focused more on that so that it was us, the leaders, the organization of the healthcare that decided the kind of technical information we need and not the technical innovation decided what the health system should do. Thank you.
We have one more question here from Michael. Michael, please introduce yourself.
Thank you very much indeed. I am Mihai Kökény from Hungary, lecturer at the University of Debrecen, former politician in Hungary, and probably many of you know me from WHO as well. So first of all, congratulations on this silver jubilee. It's really quite the duration, 25 years, even in a marriage, but also in the life of the health system. So we have heard a lot of very interesting things, ideas, expectations in terms of innovations, etc. However, what I have in my mind is that a lot of these expectations, innovations, evidences do not touch upon the policymakers, neither at European level nor at national level. Of course, we all would like to see more evidence-based strategies, reforms, even emergency management to improve the health systems. But what I have seen, at the end of the day, very often selfish interests, geopolitical contexts derail the driving values, the sciences, etc. So my question is that what should be done? How we could better approach the policy-making groups and their advisory teams. So how the innovations should be translated to examples, what politicians understand, can channel their day-to-day communication, and even to raise their responsibility for action or non-action. Thank you.
Thank you so much, Michael. So basically you say currently we are failing to harness actually the innovations to safeguard health systems. Shall we have one more question before we feed back?
I think yes. I think we're ready.
Wismar, please introduce yourself.
Vesna Kersin-Petric, I'm from the Ministry of Health of Slovenia. And I'm very much in line with the question that was put by the colleague or gentleman there. Why we don't invest more in organizational innovation, how to finance health system, different mechanisms and so on, or how to work better with some entities that are there for us, like civil society and so on. I think the answer is clear. I mean, you can, sell the drugs and the technology. You cannot sell organizational solutions so well. But nevertheless, we'll have to invest in this. And why wouldn't we consider investing through what is available here? We have WHO, we have some other institutions that try to develop some new models. And my question goes to Hans, how could we countries support this kind of organization more to, together with us, develop this kind of innovation?
So thank you so much, Vesna. So we are moving from the technological innovation to the organizational, social innovation, which are absolutely important to include them. And you say we need actually society, and it reflects a little bit what we've seen in the poll, empower people and professionals.
And it also reflects one of the questions that we got in the chat. We've been monitoring at the same time about the role of the state, be it at the member state level or at the EU level. We talk about at the international level as well, and where the state comes in. It comes in quite a lot already, I think, in the area of innovation, but perhaps which area and how much. And another comment from the chat as well that said that there isn't that much interest on the private side for investing in professional education, for investing in this type of necessary environment for the flourishing of innovation. So perhaps to complete what you were saying, Matthias, and I think that's a point where we go back to the panel, there's enough there to think about and reflect on.
So 4 big questions: international property rights, invest in organizational innovation, what can we do not to derail innovation, and how can we use actually existing organizations better? And please don't try to answer all these 4 questions, just pick the one out you feel best suited, because otherwise we don't have a second round. Hans, I think it's fair enough if you have a first go. Is that okay? You're muted, I guess.
No.
No, perfect.
You hear me?
Yeah.
Okay, good. Yes. Thank you too. Obviously, I have to answer the question first from Dr. Vesna Petric, our respected member state. And thank you, Vesna, for your drive and your great leadership as the former chair of Executive Board. So, number 1, are we fast or slow? I always say health is a global public good. So this is not just a commodity. And the health system is like a huge tanker, right? So we have to be careful to shift gears, because if we get it wrong, many people will die and suffer. So number 1. Number 2, people who know me know I'm a born optimist. I think that the glass is half full. I mean, my friends, I don't know about you, but I have been seeing innovations happening at a speed during the COVID-19 which did not happen in 30 years. Number 1 on digital health, number 2 on primary healthcare, and on organization innovation. Remember, this was the theme in Tallinn 5 years ago, and we're going to talk about this again. I would like to invite you 23 October to the Global Primary Healthcare Conference in Astana, Kazakhstan. And I'm so grateful that my brother Kairat Davletov is on the panel. 23 October, we bring together from the whole world innovations in primary healthcare. And it's amazing what has been happening, really. On tuberculosis, I came back from August from the G20 meeting. At the sidelines was a ministerial meeting on tuberculosis control. My friends, when I was treating TB, MDR TB, the patient needed 15,000 pills, 8 months of painful injection in the butt, which for children was awful. Today, first time in history, the duration to treat multi-drug resistant tuberculosis is 6 months, the same as drug-sensitive TB, and we have rapid diagnostic tests at the end of point care. So I would be a little optimistic, but everyone is right that we should better examine the enablers and obstacles to scale up innovation, which is exactly what Dr. Gon Galea and the team are going to do here, hand in hand with Dr. Natasha Muscat. So maybe I will stop here. I undescribe everything, but I think that a lot is happening. We have to document and believe, as someone was telling, in the power of partnership. I think it was Jennifer who was telling that. I wrote down, this is too much for one single country, indeed. And we are fully there to take our responsibility. Thank you.
Hans, thank you so much. And I think it was probably this glass is half full contribution, because when you talked about COVID-19 and all the innovation that came, are we sure that we are retaining them now and harnessing all of them, or are we stepping back, unfortunately, in some cases? Shall we have the next one? Isabel, just pick out one of the questions.
So for 2 of the questions, intellectual property right. For all the innovations in the health area are covered by the medical devices legislation. We already discussed many years ago when we were talking about the apps, and now for any new development. But one thing that I also think that should be discussed when we discuss the intellectual property rights is the data and the data owners. So the companies are benefiting from the data that are provided by citizens, patients, and etc., how this is going to revert. And because this is one of the issues that we are discussing currently in the European health data space, but that is part of the difficult discussions in the pharmaceutical regulation also. And we have seen some of the issues, for example, with the orphan medicines and with the request by the companies to have access to all the data of the patient to develop better medicines for them. But then the prices of the medicines go exponentially to something that nobody can pay. So we will need to have these two sides of the discussion. Regarding the changes of organizational and the health system, I think that this is what we are doing here. We have requested the observatory to work on these changes that we need to do in how the health systems are working. This is also innovation, and we have been working for years. And to fund for these changes, we have, for example, the technical support instrument that some of the countries are benefiting. So I think that we are trying to cover both sides also of the spectrum. Maybe not for sure. We need to do more, but we are trying our best.
Isabel, thank you so much. So organizational solutions to technological innovations. Please, Lisa Maria.
Okay, excellent questions. Let me pick first the intellectual property issue that Charles raised. I think they have made some progress here. And I just take one detail. I think that the academic research community was ignorant of intellectual property issues, but they have gradually started to take that more seriously. And I think that, at least in Finland, the government has tried to help the researchers in figuring out how the value chain is actually being built from academic research results to the commercialization of the product. So that's something where we can, together with other ministries, provide some assistance. And I think that academic researchers also look for advice, professional advice, more than they used to do. Maybe then I pick the politicians' responsibility or how they pay attention to innovation. I wrote down that mainstreaming is the way to go. So if the political decision-making power realizes how important research and development and innovation policy is for the whole country, then we should streamline our messages with that message. And I think that's what's going on exactly right now in Finland. And at the end of the day, maybe at the local and regional level, it's money that talks. So if innovations really have potential and evidence that they will help those healthcare providers to get better value for money, then they pay attention to also to the innovations. And for professional education, I think that also here we see some progress, particularly the technical universities now cooperate with businesses for PhD education. I think we should also learn from them.
It sounds like, Lisa Maria, that we can learn quite a lot from Finland, and Finland is already on its way, so it will be very interesting to hear more about these best practices. Please, Jennifer.
Thank you. So a quick response to the organization question. I mean, it's so true that we are myopic when we look at technology because we often think of the tech and not the context. And so in my talk, and I think, Lisa Maria, as we were talking about having some demonstrations, and there, in organizations, you have to think of what are the enablers. And of course, they are, you've got enough staff, you need to be a data mature organization with good interoperability, you need a good management culture, leadership. You need to have a method of trialing new things, such as a quality improvement system methodology. And you need to have a good relationship with the public. So those sort of intangibles, largely intangibles, are often forgotten when you think of the tangible kit. And in effect, and it's what the Institute for Health Improvement used to say from the US, the job in healthcare is to do your job, but there's a second job which is to constantly improve, and that we are only going to do this, and if there is a constant revolution, I would say. So I think that's my main response. Just on the policymakers, of course they are short-termism, aren't they? They will always be short-termism. It's not so much the evidence, in my experience, it's the will, because of thinking about electoral prospects and so on. But I do think there is a change of wind at the moment, where I think they are believing more in the long-term role of the state, not least to compete with China and to develop industrial policies. Britain is a bit of an outlier, is very limp on that at the moment. But the growing evidence and knowledge that health is linked to wealth is really, really important for the economy. And I think that is concentrating minds more than it has done for the last 20 years.
Thank you so much, Jennifer. And one of your remarks, I was reminded of this saying, 5% innovation, 95% transpiration, but now it's 95% organization, actually. So I think we need to really focus on this one. Kairat, yes, please, Matthias. Your view from Kazakhstan.
Yes. Matthias, before we move to Kairat, perhaps, may I abuse my role as a co-moderator to say, Jennifer, from your organization, we have the spread challenge, right? From where you clearly collected a lot of information about how we can actually move ahead this conundrum of having innovations but not being able to scale them up. Just for participants who might be interested in taking a look, and to reflect back to one of our colleagues in the chat who was wondering about the extent to which lessons from the UK are transferable elsewhere. I mean, I think we can say if you go through the spread challenge, you can see that maybe it won't be one-to-one attributable to your health system, but the lessons, I think, are really, really universal in that sense. Would you agree? Yeah.
Yes, thank you for that. The spread challenge had impact in government and in the NHS. And also just to say, the NHS for the first time is developing a national quality improvement system called Impact. So it's worth Googling that. It's how to get quality improvement methodology, rapid cycle innovation, formative evaluation, much more embedded. It's really the early stages, but we have some good sites across the NHS that can show this, particularly in hospitals, not so much yet in primary care, unfortunately, but I think that's the beginning.
Okay, not to add to what colleagues mentioned, as I'm not an expert in policy especially, but just want to comment on organizational structure question. We really need this in LMIS country, even probably more than in other countries. And we are looking for the leadership from the developed countries, from the European health observation. Yeah, that's all.
So you said you're looking for the leadership from the European organizations?
Yeah.
So it's a little bit what Wismar was actually pointing at, that we should better use the organizations we already have, to address these issues. Hans, you heard this, I guess.
Yeah, just because we are lagging behind in innovation, we are also, I think, lagging behind in organizational structures. Yeah.
I ask the back of the room if you have any points. You've been quiet. We've let the front dominate so far.
Behind you, Adam.
Oh. Wow. Okay.
Oh, wow.
See, that's a very nice response over here. Yanni.
Yes. Thank you. It's a great pleasure to be here to celebrate your 25th anniversary. Yanis Natsis from the European Social Insurance Platform. We've been talking a lot about innovation, and Jennifer, you also brought up the issue of the need to evaluate before endorsing it, to assess the innovation. My question is how compatible it is to do this evaluation when, especially nowadays, we see that a lot of decisions around innovation are totally geopolitical. When we see that, especially when it comes to biomedical technologies, a lot of those are decisions under the disguise of health policy, but essentially we are talking about industrial policy. And there, how do we reconcile, if there is a need to reconcile those worlds or not, how do we get to the point of having a meaningful assessment backed up by evidence, since of course we're talking a lot about evidence as well today. Thank you.
Thank you very much. I'm Claudia Marinetti. I'm the director of Mental Health Europe. So, of course, I'm going to dig into a very specific niche. And here, we talked a lot about the individuals at the beginning, and that seems to be one of the most important things, empowering people. But then when we are talking about innovation, people don't come out very much. In the specific issue of mental health, the effect of data sharing is really, really tricky because still of the stigma, because people fear to lose basically control over their data. They don't know where the data is going to be, and sometimes they don't even know whether they agree with what has been drawn up. So the question is there a way to not take basically a one whole block of this is health innovation, to focus on vulnerabilities, and when it comes with the example of mental health, the vulnerability is data leakage or loss of control is particularly detrimental when you have a mental health condition. And at the same time, there is the issue that not all innovation in mental health is considered a medical device. So not all applications are considered a medical device, because those that develop them could choose to have them as a wellness device, which would not then follow under stricter regulation. And what can be done to address this? Thanks.
Thank you very much. I see we have a lot about the definition of innovation, innovation policy, and particularities of risk in particular areas such as mental health. We have a couple of more points here from the back.
Hello everyone, and congratulations to the Observatory for this anniversary. Adam Rogalewski from the European Federation of Public Service Unions, and we represent healthcare workers from across the pan-European region. My question here is about this discussion about innovation in relations to the cost of living crisis that we observe across the globe, I think. And we know that there will be another issues that the governments need to deal with. We know that the healthcare workers are going on strike in Finland, in the UK. So, I mean, what's the panelist could reflect on that? Because I think what we are doing now in the healthcare sector, we try to actually survive the pandemic. We try to ensure that we deal with the staff shortages which are there. And how innovation, so focus on innovation, could help us to deliver better outcome. And another question or point is the importance of public sectors, not only private sector innovations. We know that public sector developed internet. No, that was the researchers who did it. So I think it's really important the role of public sector to ensure that it's also leading on the innovation. Thank you.
Dennis. Thank you so much. First of all, I see that observatory and all people are very young. You all are only 25 years old, It means that we see good perspective in the future, next 25 years. But may I turn to such, very important question about societal conundrum, because we have three areas. First of all, evaluation regulatory efforts, then stakeholder awareness and growth in innovative technologies. I remember very well when we presented a regulation health technology assessment. It was in 2018, and finally it was adopted in 2022. At that time, innovations are with light speed going up, and the regulatory frame is very old one. And we see old mechanisms to react. My question is, especially for Isabel, it is possible to create much more effective mechanisms, responding to those innovative needs in area of regulation, including Commission, European Parliament, Council, and Member States. That's a very general, simple question.
Super question. Thank you so much, Bettinis. Can we now have...
We have more questions, but I think they may become too many because I see at least 4 more. Nick has been very patient waiting over here, but we have others waiting. Maybe we go back and then we have another round after. Yeah?
Nick or?
Sure. I mean, I thought maybe it's time to go back, but maybe we have a final one from Nick and then we go back.
Oh, that's very kind. And also my warm-heartedly congratulations. Well, maybe a little bit, a small story about the Netherlands. So when I in my early career, I was in this area, generative medicine, robotic surgery, early stage artificial intelligence. And at the time, the Netherlands was setting up with 8 university medical centers, these innovation clusters. And they became very powerful economically, science output, and all kind of so-called innovations. Currently, we're at a stage that the cost of healthcare in the Netherlands is going to the roof, totally unsustainable. We did a study some years ago that 2/3 of the cost rise is explained by innovation, technologies, etc. And only 1/3 is explained by demographic growth. So if you look to the outcomes, actually, precision medicine, etc., the improvements compared to what we have is not that impressive. So you could say we have good innovations which really helps people and which might threaten the healthcare system because they are too expensive and are maybe effective for a relatively small community. So if you look to elderly care, or care, child care, mental health care, we are really not doing well. It's not integrated. We're still faxing for exchange of information, although the hospitals say we have artificial intelligence. So there are some paradoxes. And I think this story of biomedical innovation as promoted also in some other clusters across Europe, across the world, where medicine, medical technologies, etc. Is this still the way to go, or should we have a different tune on how we innovate? Thank you very much.
Thank you so much. That was a very thoughtful contribution, but we had a lot of very thoughtful contribution and quite a spread of topics we had. The question whether geopolitics and industrial policy is actually affecting our innovation, how we adopt them. We had a question regarding mental health and vulnerability, is it really taken into account when we innovate? We had the question of cost of living, and I think it links a little bit to what Nick was actually now saying. And we had from Vitenis the question, how can we actually have faster, more effective regulation that is not outdated by the time it's eventually agreed upon? So big questions, and again, please don't try to answer all of the questions. Pick the one out you feel best suited to respond to. Hans, can we start with you again?
Thank you. You hear me, Matthias?
Perfect.
Okay, maybe a one-liner to give more space to my respected colleagues. I know that Dr. Josep Ramagosa is connected, respected colleague from Ministry of Health of Andorra. And one time he told me, Hans, what is innovation? Innovation is implementing what we know is working. And I always remember this, and I think this is something we should keep in mind. Thank you.
That's great. Thank you so much, Hans. Isabel.
Okay, for the legislation, you were there. We can do a lot of things, but we need the support of the Parliament and of the Council. And sometimes it's very difficult to initiate something that nobody is requesting, or that we know that is not going to have the support. We already have that in the past. For example, when we had in the pharmaceutical sector the information to patients, that is one of the few legislation that were withdrawn because it was not responding. So we can begin to do any new legislation, but taking into account if this is going to be supported or not, and also the time is crucial. During the times of the pandemic, so we were able to make pass the regulation on cross-border health threats and the new configuration of the ECDC at the EMA, because it was the pandemic, and that took a very short time and was 2 years. So usually it takes much more, but 2 years for me is already enough. For the cost of innovation, I mean, what we need to take into consideration is, are we ready to get rid of some of the innovation, or not to take some of the innovation? Because I mean, I'm wearing these hearing devices that I know that, well, that they are very expensive, but I'm ready as individual not to have them and have something like that will be attached to my head. No, and I'm ready to pay. Yes, I am ready to pay. Is the society or my insurance ready to pay? It seems that yes. So one thing that I love that you did in the Netherlands many years ago, 30 years ago, was the Dunning report. Nobody has done that anymore again, and I think that we should do that. What the health system should to cover, and what the citizens, if they want that, should cover themselves. I mean, this, because, yeah, 2 years is innovation, but what are we ready to not to do? And for the mental health, one of the issues, well, in general, not just mental health, but in general, the only regulation that we have to cover all those issues is the data protection regulation. But the national pieces of legislation that exist in many member states about the information and the consent of the patient doesn't exist at EU level. And will be, I think that in one side will be necessary, but in another side we don't have the competencies to do that. But we could be discussing those issues. And it's not just, I mean, it seems that maybe the mental data are more confidential, but no, I mean, why to be labeled as a cancer patient with all the consequences that could have, or in other areas, is also important. But maybe it's something that we can begin to discuss. Are we ready for more advanced legislation, whatever the kind, in this kind of issues that are not really properly covered by the data protection legislation, and to which point are we also ready to give those data to other companies, services, etc., because we are going to receive something in return of providing that information.
Isabel, thank you so much. That almost sounds like a suggestion for future health priorities of the EU. Jennifer.
Thanks. So maybe I can roll the one answer to 3 questions. And I think there's the big issue for me here is, you know, in Britain, we've been absolutely hammered by the pandemic. We have so much debt as a result. Politicians are absolutely focused on growth, trying to get growth in the economy. So for them, linking that with life sciences and innovation is one of the primary objectives. And they often view, at least particularly the current government, but not just this one, often considers government spending on health to be a drag on the economy, and something they'd rather not think about. They don't see it as part of wealth generation. So I think part of the issue here is to show those links between health and wealth, particularly looking after the working age population that is going to be hammered in future by having to support lots of older people, as well as supporting older people to retain independence. So I think...
Can I ask you, has the discussion and the policy in the UK, hasn't it been much more advanced in the past, actually, that health and wealth was already kind of connected?
I think it's getting there, but it's still not following through into investment into the National Health Service. And one example, the irony, is that while funds are available for life sciences, there's also had to be a cut in the technology budget to the National Health Service because of the economy, you know, the budget being so squeezed. So that's an issue, and then that means that we can't follow through in developing labour saving to try and address the shortage of staff that's global, labour saving technology, which is going to have to be front of mind. So I think this is partly about a narrative and about evidence, and it's also far better demand signalling by health services, the NHS in particular, to a very powerful life sciences industry that's got the wind in its sails because of its part in a hopeful growth story. Thank you.
I guess that was the glass is half empty contribution, actually. And I'm a bit worried that Joseph's curves, the 3 curves he showed at the beginning, you know, is going to perpetuate, actually. You know, that could very much happen, Joseph. Please, Lisa Maria.
Okay, so many interesting and important issues. I try to be quite brief. Just one detail on the mental health issue. Finland has had this legislation on the secondary use of health and social data. And individuals have had the right to opt out by contacting the authority who is managing this, the legislation in practice, FinData. But what we have been seeing over the years is that very, very few people actually have opted out from the secondary use of the data. When it's being regulated, it is being regulated and handled the way that Finland has been operating on it for a few years now already. So this is an observation. And I think personally it would be a pity if we couldn't have access to that data that's originated in mental health and abuse services, whatever you call that, because then that sector of the health services would be lagging behind from all the options and opportunities that the secondary use of the data is providing. Then about the cost of living crisis and the role and the salaries and everything about the professionals. The ministry in Finland has no role in the labor market. It's other parties there. But I would like to say here that I'm a little bit worried personally about the image of the health and social care professions compared with other industries and educational options that young people do have. It seems to be that our sector is not that lucrative anymore, and that is being reflected, among others, in the salary levels. And then there were many issues, questions about meaningful evidence, cost, and so on, and I thought, well, come on. We as health systems, we are powerful legislators, regulators, purchasers. We should capitalize on that.
Yeah. I think for our region is one of most important questions, comment that Nick made. So how to avoid this, mistakes in the implementation of innovation in health practice, and this is a real problem, I think, for our countries, and we have to learn from the lessons from other countries, from already passed this way,
Very good. Thank you so much, Kyra. Dimi.
Thank you, Matthias. We have 3 minutes left, I think, in our slots, and we have lots of points on the floor. We're going to take 2 very brief points from the floor, and I'm going to bring in 2 points from the chat. One being, how do we actually motivate everyone within the health system to innovate in the area of prevention, including the population? The other one is about the role of young people, seeing as they are the ones who might be more likely to adopt innovation and the ones who are going to suffer the consequences in the long term of not adopting it. Should we appoint them in leadership positions and be done with it? That's the question in the chat. And then I'm going to have 2 colleagues from the floor with the request to be very, very brief, because we will ask our panelists to give us a short concluding thought on whichever one of those you like.
Thank you very much. Dana Burdujan from the European Investment Bank, and my question goes straight to Joseph. Coming back to the poll that was so surprising at the beginning of the session, while everybody seemed to be happy with the level of financing invested in innovation as it came before last, while we at the bank, for example, that we support innovation in life sciences area, know that the situation with the innovators in that space, meaning not academia, but also not fully deployed solutions, they're really struggling. And I think at the level of the European Union, it's the same for other sectors that deal with innovation. So maybe it's rhetorical, I don't know. I'm just saying that we in the room and what we hear from the companies that are really involved in innovation seem to be 2 very different things. I mean, for us it's very low, for them they seem to struggle. Thank you.
Thank you very much. And one final point. You have a microphone already? No.
Thank you very much. My name is Maria Cristina Profili, and I'm the Senior Regional Advisor for Health Migration in the IOM, International Organization of Migration. Formerly I was with WHO for a quarter decade. Thank you for the invitation. I think Joseph reminded us about SDGs, do not leave no one behind. So my question is also reflection. It's how we can ensure that this tsunami, storming of innovation, can really make sure that the migrant or refugees have access to the basic health care. One question. The second is how we can make sure this storming of innovation in a positive way will be a good reflection on mobility migration, because migrants are moving from country to country. Thank you very much.
Thank you, and I think this is a specific perspective on looking at this issue of balancing a lot of innovation and ensuring our basic principles of access to care for everyone. I think we come back to you, to our panelists. Maybe we start in the opposite sequence from which we started in the previous rounds. So Kairat, if you would like to reflect first, briefly, thank you.
Okay, thank you. I think in the summary, what we hear the most is not like concern, but about challenges which we are facing in this way of passing innovation. And I think this is, government will play their role, but international organizations, and especially WHO, and especially in our region, has to play a very important role, because in our region, WHO position, WHO direction is very sort of authoritative, is very important. And due to some just lack of capacity or lack of knowledge, we need more like, technical assistance from the international organization. Thank you.
Thank you very much. It's really good that you remind us of this issue of capacity and the importance of collaboration and exchange. Jennifer, over to you.
Thank you. Are these concluding remarks as well? Yes. So just to say, not glass half full, half empty rather, but half full. I am actually very optimistic that in health we can really harness innovation. I think we've got very important assets that we shouldn't underestimate. We've got really good building blocks, whether it's data, we've got science, we've got very well-skilled staff and a very motivated group of the public as well using services. So I'm very hopeful that we can identify and overcome barriers. I think really we have to be bolder than we have before and more flexible. We really have to take some risks here because we're going to be overtaken otherwise. And I do think it's important to reach out to young leaders, particularly not just because they may be more tech savvy, but also because their attitudes and flexibility may be greater, and that's what we need to demonstrate more of. Thank you.
Thank you so much, and very happy to hear you're optimistic.
Well, I'm also optimistic here. Imagine if we would be practice medicine, be it preventive public health, clinical medicine, whatsoever, epidemiological research, the way we did it in the beginning of the 80s, when I started being an active professional in health. If nothing had changed, would we be pleased? No, I don't think so. So, well, I think that the key is that we are humble enough to pay attention to what's going on in basic research, biomedical research. Where is the research effort going right now? Where are those big obstacles, those big questions that we haven't been able to solve and that community is trying to find out the secrets of the nature? And then bring together that knowledge, information, and horizon scanning together with the clinical community, the public health community, and the health systems researchers. And I think the observatory is one of those platforms that could do it.
I think that we are always complaining, but that in reality our health systems are much better than what they were 30, 50, 100 years ago. So there is room for improvement, but we are in the good direction. We are never going back, I think. And also the observatory, that is what we are celebrating today. They are there to support us, they are there to, or you are there, or we are there, I don't know how to say, but everybody is involved, and to guide where to go for having even better health system, but I am very optimistic about the future.
Thank you so much, Isabel. Hans?
Thank you, Matthias. And I think I saw also in the room Dr. Clemens Ohr, present from Gastein, who I would like to acknowledge also, because I think Gastein has contributed a lot also to this field of innovation. Second point, to Professor Kairat Davletov. I hear your call, my dear friend, and actually, a couple of days ago, I came back from, I think, historical meeting in Dushanbe. For the first time, regional director was invited to participate at the annual meeting with the 5 presidents of the Central Asian Republic on invitation of the host in Dushanbe, Excellency Emomali Rahmon, and they approved the first sub-region strategy on health and well-being. So I think this is a great step forward. And then my final point, I would like to pick in on one intervention on mental health, because this is very close to my heart. It's a flagship of the European Programme of Work. And the main innovation we see there is to put the people, not at least the young people with lived experiences, in the center of the service provision, including peer-to-peer support. And that will be the core of the high-level meeting by WHO in Tallinn, 12-13 December, to put the frontline workers, including informal workers, I think there was also an intervention on this, and the patients up front to co-create the solutions. Because if we listen to those people, it's remarkable what we can do. Thank you.
Thank you very much, Hans. Thank you very much, everyone on the panel. I think a big round of applause is in order. And it is now a pleasure to introduce our Deputy Director and our Co-Director, Suszy Lessof and Martin McKee, to reflect and close the session.
If we go up there, you'll be able to hear us better, maybe, or see us better. Martin is going to start.
So do you want me to? I'll kick off. Okay, thank you very much indeed, and happy birthday, Observatory. So I've been asked to come up with a few concluding remarks, which is obviously extremely difficult given the wide range of issues that were covered, from health technology assessment to intellectual property to whatever. But one of the things I was struck by came up a number of times. Joseph asked repeatedly about the affordability of innovation, and I agree. Earlier this week, I was really concerned when a new device came onto the market. And I looked at it and it cost an awful lot more than its predecessor, and I really struggled to see whether the improvements actually justified that much higher price. And then I looked at how much we were spending on this item of equipment compared to the past, because 30 years ago, we actually spent nothing on it. And now we're spending, difficult to get the exact figures, but about $40 billion worldwide. So what is it about iPhones that have taken over our world? Why are we allowing this to happen? So I guess the difference is that when we buy an iPhone, we pay for our own iPhones. But when we pay for health technology, the rich in general pay for the poor. So the question to me isn't, can we afford it? The question is, do we choose to afford it? And that takes me back to something that Joseph also mentioned, and which we've had a lot of discussion about in the last few weeks, the Lancet editorial by my very good friend Richard Horton. And essentially, he was saying that primary care was not sufficiently ambitious. And this has been heavily criticized by a number of people. Essentially, he's saying that primary care is fine, but we actually need other things. And I think what's interesting about that is that it's always good when we look at innovation to put ourselves in the shoes of other people. Now, what Richard was doing as a survivor from cancer was putting himself, I was going to say in the shoes, but of course many of the people involved in Africa don't actually have shoes, of people with cancer there and in other poor countries. And he was looking at it from their perspective. So when we talk about the affordability of technology, in a world where we spent so much money on weapons, on all sorts of other things, we have to ask ourselves, not can we afford it, but do we choose to afford it? Now that doesn't mean that we then ignore the basics, because as Kairat pointed out, we have statins, which we know are life-saving, and yet only a fraction of people who could benefit from them actually do. Now let me just come on to innovation, and I want to come back to something that Hans talked about in particular, but others did too. Innovation, I don't think, is optional. The pace of change, and Lisa Marie, many of you actually raised this, Jennifer as well, the pace of change is accelerating, and the health sector cannot and will not be left behind. But equally, we must not let ourselves get too far ahead of what is happening, because there are many people out there who have a long record of predicting the future in great detail and being completely wrong. Now, I think it's always important in the observatory we like to learn lessons from others and lessons from elsewhere. And so therefore we are very grateful to those countries that are often rushing ahead with innovations and then making mistakes, because we can learn from them. It doesn't mean that we want to copy them until we've actually seen the results. But I think with innovation we just do need to be a bit careful to get the timing right. We don't want to be the ones that are in the vanguard. We don't want to be the ones that are charging into battle. I was involved in an exercise looking at a particular plan on workforce in one country that shall remain nameless the other day, and the analogy we used at the end was as if the government had set out a plan for the D-Day landing, and everyone was on the ships going towards Normandy, but nobody had actually told them what beaches they were going to. So we just need to be a little bit careful in all of that. But if we are going to be aware of what is coming over the horizon, then we need to understand the risks and the opportunities, and this requires a new set of skills. But unfortunately, these are skills that are in very short supply, and they are highly valued by people other sectors who have much deeper pockets than we have. But innovation is only one part of the issue, of the challenge going forward. And as Hans reminded us, at Tallinn 5 years ago, we created a vision in which innovation sat beside inclusion and investment. The case for investment should be obvious, as we are still emerging from a pandemic whose impact was far greater because many of our countries failed to invest after the financial crisis when they should have done so. Not all politicians agree with that, and you can look at my writing on that elsewhere, but most do. But clearly, as we look around at the financing for all sorts of things in the global agenda, that message has still not got through, so we still need to make the case for investment along with the innovation. But the one that I'm most concerned about, and that came out again from many of the speakers, was the third I that Hans came up with in Tallinn. And of course, at this stage, remember, we will be back in Tallinn next year. We talked, several people mentioned trust and transformation. And that is the inclusion, because time and time again we've made mistakes because we do not include those who are affected by the innovation or who we need to understand what they're doing to make things work. Because none of this will work without trust. We will not get the transformations we need without trust, which is the topic of our meeting in Tallinn in December this year. And unfortunately, as we look around health systems all over the world and politics all over Europe, we see that trust is perhaps the thing that is in the shortest supply. Thank you very much. Suzy.
Thank you, Martin. I've got one. Thank you, Martin. I think Giuseppe mentioned at the beginning that we were very consciously not going to spend the anniversary celebration talking about ourselves. And I think that's been a good choice. It's been a really genuinely interesting session. But it would be very wrong not to talk a little bit about the observatory, I think. In keeping, though, with the theme, I'd like to talk a bit about the observatory as innovation. And I think Hans and Vesna, you mentioned at the end of the session in the questions that innovation's not just technological, it's also about organizational. And I think that the observatory is a really good example of organizational innovation. And so if I could have a couple of minutes just to reflect on 4 areas and to thank people. So the areas I think are partnership, the secondary research approach that we use in our meta-analysis, the way that we work and knowledge brokering, and change. I think the partnership one is probably the first one. I can't see hands, but the partnership of the observatory has been a remarkable thing, and I think a very innovative thing. So for WHO, it hasn't always been the easiest thing. We are the first partnership inside WHO that's been properly hosted, and we have learnt together how a very official, very internationally focused organization can accommodate something which is by design small, light on its feet, and very reactive. And I think the way that we're able to collaborate and work with Natasha shows that that innovation really does work and that it's really win-win. And Isabel, I think the commission work that we've done together, you've always known about evidence, supported evidence, but you're using evidence with us to help us support you as you brainstorm and you decide what to do next. You are helping us with how you speak to other DGs using the state of health evidence and how we're able to support and work with cancer, with GGRTD. But also, I think you mentioned the TSI and the DG Reform Project, and there it comes back to our member state partners and the countries. There's been an amazing amount of innovation. Member states looking to the Commission to change the way its instruments of support are helping them to make change in countries. So Austria, Belgium, Slovenia, you're really at the forefront. You're innovating and we're learning from the innovation, and I think hopefully supporting you with it. And in fact, all of the countries that are part of the observatory have been amazing in terms of a new way of understanding the interaction between policymakers and evidence providers. So there's a real chance for us to have entry points and us to learn from those entry points. And I think that has been new and it has been useful. So the work that Finland has done on innovation with DIMI and with CNAMS, also that is the French social health insurance body, John's work with the Irish partner on the reforms there, and all the EU presidency options where we have been able to feed into Sweden's work, to Slovenia's work. But we're aware also that not all of our partners are member states and of the EU. So Switzerland, the UK, we've done work with Norway, and we're learning about that perspective too, and with the Health Foundation, Jennifer, from non-member states. And I think it's been a new approach, a new kind of interface. And the second thing I would say, which is perhaps not unconnected, is that we have an innovative secondary research model. We have the most amazing academics that work with us, but they do primary research. So they're really looking at the detail and the analysis and drilling down. And I think what the observatory's been able to bring is innovative in that we put them together so people from different silos talk to each other and understand the connections between the areas. We bring policymakers into the room so that they understand that however good their analysis, if it only sits on the shelf, it perhaps hasn't been as useful as it might have been. So I think there's been lots of efforts there to be innovative, and it wouldn't have happened without the generosity of those academics. And I just want to mention one more academic innovation, if you like, which is the HSPM, the Health Systems and Policy Monitor, which is a network of experts in countries who update what's happening, capture reforms. A very innovative platform in many ways, and something that Reinhard, Ewout and Anna, who aren't here, have really developed. And again, I think proof that as an organization, if you do things differently, you can get different knowledge and information out of that. The ways that we work in terms of understanding knowledge brokering, we understand that from the partners, so I can loop back to you all. We need to have key messages. We need to make the very long work short. We need to have the detail behind it, but we need to be able to explain what it says succinctly. Eurohealth articles, the website, policy dialogues. I think we wouldn't have done that without the partners. I know we wouldn't have done that well without the partners. And I think that that has also been innovative. But my last point, really, before I get to my thank yous, is about change. Some of those things don't sound innovative anymore because we've been going for 25 years, and when we started, people weren't so aware of these things, and we're not by any means the only people who are aware of them, but we have learned and we have changed, and I think with the partners and this particularly dynamic combination, we need to keep changing. So we've all talked about 25 years, and I think that's been 25 years, and I think it's Trotskyist to do continuous revolution. So maybe not continuous development, And I think, no, Deborah wants me to say learning from each other. So what we've had is, I think, 25 years of continuous learning from each other. And we very much look forward to 25 more years of learning from each other. And then I would like to say some thanks. And if I do these back to front, it's going to be a bit weird, but thank you very much for coming. Thank you very much for staying as I finish to have a group photograph taken. So that's my first backwards thank you. Then I would like to thank everybody who organised this, particularly, of course, Shora and Deborah, who've done an amazing job. It's a lovely place. And then can I do... I'd like to thank, again, the partners. It really is what the observatory is about. But I'd also like to thank everybody who's here and who works with us, because I think you heard from the questions and the debate today what it is that we get out of this interaction, the ideas coming up, the suggestions, the experiences, the perspectives, thinking about it from the individual perspective, thinking about it from terms of migrants. All of these things really matter, and they're very easy to forget if you're working on your own in a sort of very focused way. So thank you to all of you. Thank you very much again to the partners. And can I now thank the staff team, because we have an incredible staff team in different places. In London, we have fabulous people. In Berlin, we have an association with the Technical University of Berlin, so there's lots of people working there who aren't staff, but who are phenomenal. And this is years and years of really amazing people working very, very hard. And in Brussels, an admin team who are phenomenal. And also, Dimi, John, Ewout, Matthias, a very senior, very committed team, and Giuseppe. I won't say anything nice about you because it will make me cry, but you have been an amazing director for 25 years, and we all appreciate you very much. Thank you.
Very good. Who's going to start the mic for a photo?